Okay. Certainly want to welcome everybody to this week's happy hour session. We're very pleased to have a guest dermatopathologist, Dr. Connie Fiore. Connie is at Geisinger now and is doing her completing her fellowship there, and did her dermatology residency in Texas at Baylor in Dallas, and will be headed back to Texas. Correct, Connie?
Yes.
After she finishes her fellowship. So we're anxious to have her back, and really appreciate her participating, and can't wait to hear what she's going to teach us. So I'll turn it over to you, Connie. Thank you.
Thank you. Thank you, Dr. Davis.
Mhm.
So I picked out some cases that I think are not only interesting, but potentially board relevant. We don't want them to be so interesting that you'll never see them. But how I like to go through these cases is how I like to go through cases just in sign out. So that would be description, and then coming up with the differential, and then the diagnosis. So this first case here, we have a shaved biopsy, and it looks like it was bisected. And already from low power, you can see that there's a vascular proliferation, and it looks like at least the superficial dermis. We don't see the deep dermis to know. But going in a little bit closer, you can see that these are vascular structures, and they're ectatic vessels, and there's also some cells in between, in the dermis as well, between the vessels that we can see. So going a little bit closer, we look for clues. And here it's a little blurry, but you'll see on the exam, the digital slides are not that clear, so it's actually good to get used to looking at slides this way. But here you can see that there's hemosiderin in the dermis, so potentially some extravasated red blood cells here, some hemosiderin, these ectatic vessels. See a little bit more hemosiderin here. And when we have two pieces, in real life, you should look at both pieces. And here you can see that there's extravasated red blood cells, hemosiderin. So here you might have a couple of histologic differential diagnoses. So looking at ectatic vessels with hemosiderin, you could think of something called a Targetoid hemosiderotic hemangioma. You could also think of maybe Kaposi sarcoma, because we did mention that between these ectatic vessels that there's a more cellular component in the dermis. So keeping that in mind, those two might be on the differential. I think those are the top for me when looking at this. And then a little bit about the clinical might help you too. But I think the overall histological features here with ectatic vessels, a little bit of a busy dermis, and then extravasated red blood cells with hemosiderin could lead you towards a Targetoid hemosiderotic hemangioma. Now, in the books, you'll see that they don't always like to call it this because, one, clinically, it may not be Targetoid yet, or might not appear to be Targetoid. And then secondly, it might not be hemosiderotic. You might not find hemosiderin necessarily. So the other name for this would be Hobnail hemangioma. And so looking at these vessels a little bit closer, you can see that there are endothelial cells that are kind of plump, pushing into the vascular space. So that would constitute Hobnail endothelial cells, and therefore Hobnail hemangioma. So they like this term. However, I mean, not all Targetoid hemangiomas or Hobnail hemangiomas actually have this prominent hobnailing of the endothelial cells. So another thing to mention here is, besides vascular markers like ERG, that these vascular proliferations actually stain for D240. So it tells you that they're from a lymphatic origin as well. So you know that there's lymphatic differentiation within these structures, despite them looking more vascular. And so these typically occur in young to middle-aged adults, male predominance, and it could be on the trunk or the limbs, and it could look targetoid in appearance. So meaning like there's hemorrhagic like purpura, and then you might have this violaceous hue around that area. So a targetoid appearance, and that's where it gets its name. So if you're really trying to differentiate this from Kaposi sarcoma, you could easily do an HHV8. It would be negative here, and with the clinical, you could diagnose Hobnail hemangioma or Targetoid hemosiderotic hemangioma. So going along with this, I kind of have a little bit of a theme to compare. But the next case, again, we have shaved biopsy that's been bisected. And here, looking at low power, you can see that there are vascular or lymphatic spaces in the superficial epidermis, protruding into the epidermis, as well in the superficial dermis. And just looking at it from low power, you could already see that there's some fluid in here, but it's not necessarily red blood cells. Here we see a little bit of red blood cells, but it's good to take the overall impression from low power before you go to higher power. And here, getting a little bit closer, you can see that this is lymph fluid in this space. You could also see a little leaflet here. Moving over here, you can see that there are red blood cells in this space. But this kind of contrasts what we saw earlier, but dilated spaces, whether lymphatic or vascular. And here we know that these are lymph-filled. They're going to be positive. These walls, these endothelial walls, will be positive for D240, just like the prior case. But with the lymph fluid in the leaflets, this would lead you towards lymphangioma circumscriptum. And you kind of see more here, just showing, but dilated spaces pushing up into the epidermis with lymph fluid. Sometimes you could see some red blood cells in there, and as well, this looks like it has a little bit of thrombus inside of it. So these typically present earlier in life, like in infancy. It can present in the limbs, limb area, and they have this appearance where they're translucent vesicle spaces, and it's been likened to a frog spawn. That's how they usually describe it. I've seen it in very unusual places as well, like on the tongue, but this is how histologically they'll appear. So going on with the same similar theme, the next slide. So again, we have shaved biopsy that's been actually trisected here. So you can look at all three pieces. And it looks like most of the process is in the middle piece here. You can see that this process is in the dermis. And already on this magnification, you can see that the dermis is very busy and there's quite a bit of extravasated red blood cells. So kind of mirroring what we saw before with the Targetoid hemosiderotic hemangioma or Hobnail hemangioma, you see that there's a lot of extravasated red blood cells. And here we have much more of a busy dermis, but this is in contrast to the first case, much more busy dermis. And you can see coming up closer that these are vascular proliferations, and you can see that they kind of have these clefts around the vascular proliferations, like here. So this is not quite as well formed as you would typically see in other cases, but this is the beginnings of what you could consider like the promontory sign in Kaposi sarcoma, but you have pre-existing vessels, and then you have a vascular space forming around that area or that island of vessels. So not well formed, but starting to get towards what you would consider a promontory sign. And then very busy dermis, and all of these are endothelial cells, extravasated red blood cells. And I'm sure if we look closely, we might be able to find hemosiderin, because where there's extravasated red blood cells, you can find hemosiderin. But if you remember, in contrast to the first case, this does not have the same ectatic vessels, and it goes a little bit deeper. It's much busier, and there's hints at the promontory sign here. So if you were to stain this with D240, ERG, you could stain it with all the vascular markers and they would be positive, as well as HHV8. So this would lead you to the diagnosis of Kaposi sarcoma. And usually the promontory sign is more evident in patch stage Kaposi sarcoma, rather than when you get towards nodular stage, then you're less likely to find the promontory sign in that stage. So this would be closer to patch stage Kaposi sarcoma. And going over the clinical, just remember that there's classical forms of Kaposi sarcoma. There's endemic forms like in Africa, as well as immunosuppressed forms. And then lastly, related to HIV/AIDS infection, Kaposi sarcoma. So we're switching gears a little bit. So here it looks like we have potentially a huge scoop shave, and you can see in the dermis that there's this proliferation, so neoplasm here of some sort, and you could see from this power that it's in its own stroma compared to the stroma surrounding it. So here is what we have, our little bit of more normal stroma. Here it's getting a little bit busier, so this would be more of like a fibrous stroma. You could also see that there's inflammation, so it looks predominantly lymphocytic around here. And you see these basaloid islands inside this fibrous stroma. So getting a little closer, you could see that there are these basaloid islands, and there's cleared out areas in the basaloid islands. And just getting a little bit closer, you can see that these cleared out areas have lymphocytes sprinkled throughout them. Here's that lymphocytic inflammation there. But these islands, they're throughout in this fibrous stroma, pretty well circumscribed neoplasm. So even if you didn't know anything about what this entity is, you can see from this that it's probably benign, it's well circumscribed. And then it might remind you of other entities, but it looks follicular. So this looks like it has outer root sheath differentiation because of the more clear cell area in the center. And then if you know what the overall entity is, so follicular basaloid buds in the dermis in a fibrous stroma, well circumscribed, you might get to trichoblastoma. So this is a variant of trichoblastoma because it's cleared out with lymphocytes. So this is a cutaneous lymphadenoma. The other name for that is an Adamantionoid trichoblastoma. And so the clinical then would be very similar to a trichoblastoma, but typically you get a slow growing nodule on the head and neck area. It could be in other areas of the body as well, like on the trunk or extremities. But benign follicular tumor neoplasm. And this one, very similar, but you can see that it's a well circumscribed. We can't really see the base of it, but you can kind of see from the periphery already normal stroma, and then it gets much busier, and then we have a basaloid proliferation. So fibrous stroma, basaloid proliferation, and things to take note already from low power is that these basaloid islands are very large nodules in the fibrous stroma, and it goes very deep. So potentially here you could see a little bit of sub-Q, but it's taking over the dermis and it's extending to the sub-Q. So that tells you how big this is. So I would have a differential for this, and I think this is a little bit hard to differentiate, but trichoblastoma, which we were talking about previously, this one doesn't have the cleared out spaces. You could tell it's follicular. It doesn't have the cleared out spaces. So trichoblastoma, the normal variant. And the other thing you can consider would be trichoepithelioma, which exists on a spectrum with trichoblastoma. And I think it's actually debated whether they're two separate entities. Some people like to lump them under trichoblastoma together. But the way I differentiate them is looking at this. It's very large. It goes from dermis to sub-Q. And then the islands themselves of the basaloid cells, the nodules are very large. So that can be a clue towards trichoblastoma rather than trichoepithelioma. So these lesions, whether trichoblastoma or trichoepithelioma, may have papillary mesenchymal bodies. This one, actually, I couldn't find well-formed ones in here. There are areas that kind of look like they want to form papillary mesenchymal bodies, but usually it's like a swirl of that fibrous stroma where it looks like it's a circle indenting sometimes into that basaloid stroma, or sorry, the basaloid neoplasm. But here, I didn't really see good examples of that. I think that one other pitfall, if you're trying to differentiate the two, is that some textbooks will say Swiss cheese pattern is trichoepithelioma, but trichoblastomas actually can be described as cribriform patterns sometimes too. So meaning these spaces in the actual basaloid islands. And some people will use that to say trichoepithelioma, but technically both of them could kind of have that. So trichoepithelioma, if you're trying to separate them, would typically have smaller basaloid islands, and sometimes people will describe them as epithelial fronds, but these are much larger, so this would be trichoblastoma. And we kind of already talked about it as far as the clinical, but this would present as a nodule in the head and neck area. So here, shave biopsy again. And we have this epithelial neoplasm. And some people say that these from low power look warty, so like a verruca, but not quite. Another way to kind of look at this from low power is that it's an endophytic growth from the epithelium above. And then you could already see the contrast from the epithelium. Here's the normal epidermis being more purple, dark in color. Here it's a little bit more clear. You could already see from low power. So a couple of things already start running through the mind as far as the differential. And again, pretty well circumscribed lesion. So you're thinking potentially benign again. And looking a little bit closer, you could see that this cleared out space has outer root sheath differentiation. There's a little bit of basement membrane within this lesion as well. And you could see that it's a little pink around here, around the actual neoplasm. So prominent basement membrane around the lesion. This one's a little bit interesting because if you go on higher power here, you could see that there's squamous eddies inside these glycogenated areas. So again, taking it all together, we have this neoplasm that's endophytic coming off of the epidermis. And there's a glycogenated area, prominent basement membrane around it. And then we have this area here with the basement membrane within it, a desmoplastic area. And then even the tumor itself, you could see that there's kind of like an eyeliner sign on this tumor. So this is one that we already looked, but I would look closer just to make sure that there's not any atypical cells, to make sure that this isn't a squamous cell hiding in here, a squamous cell carcinoma in situ hiding in here. But we don't see any disorder. And if anything, it's just glycogenated, cleared out cells. So taking this all together, this would be a trichilemmoma. Then there's desmoplastic features within this one. So you could go all the way to say desmoplastic trichilemmoma. And I wanted to point out this area earlier because there's squamous eddies in here. And that can happen in trichilemmomas. Some people will say that there's overlap with another entity that we'll talk about next. But just note that this can happen. This can also happen in irritated seborrheic keratoses, but these are squamous eddies here. So this is something that we can review, but if you weren't really sure about what this entity was, you can stain it. So PAS would stain the basement membrane. And then you can stain it with CD34, which would actually stain these glycogenated cells. And so based on those stains, you can then be more reassured that this is a trichilemmoma. And these can occur as a solitary lesion on the face, or you could have multiple. So if you have multiple, then you have to think of Cowden syndrome and P10 mutation. So you're kind of going down a more concerning genetic abnormality at that point. But this can just occur on healthy individuals without that syndrome. So let's contrast this to the next case. So this one has two pieces. Looks like it's a shave as well, pretty large one. And you could already see, I have to zoom out quite a bit, but you could see that this had a lot of hyperkeratosis. It's almost like a horn verrucous appearance from low power. So like the prior one, people might call these warty. So that would be correct. So these kind of have that warty architecture from low power. And even if you were looking at the top, maybe if we only shaved the top, you could see that there's this epithelial projection and potentially some perikeratosis. And so in these dilated vessels, so you might think it's a wart if the top of it was only shaved off. But we see this beneath, and here we have a neoplasm again that's endophytic, just like the prior one. And here you could see throughout this one that it has a bunch of squamous eddies, a ton of them. So these swirls here, and you can see that they have nuclei. So this would contrast to a keratin pearl, which would not have these nuclei, but these are squamous eddies. So this is filled with squamous eddies. It's a little bit clear here, potentially, but the key here is that it's filled with squamous eddies. And sometimes there's a little bit more overlap with the previous one, but this one's endophytic, a ton of squamous eddies, warty-like. And even if we look at this second piece, similar features. See a ton of nuclei, and there's swirls of squamous eddies in it. This one would be very important to look for atypia to make sure that it's not like a squamous cell carcinoma in situ. And I've seen some that were very tricky and difficult to differentiate. So just looking, I don't see anything concerning about this. So this would be an IFB and IFK, inverted follicular keratosis. This is one of actually my favorite diagnoses. Not really sure why, but I really like the squamous eddies. But like I said, you can actually see squamous eddies in seborrheic keratoses that are irritated as well. So some people, potentially the ones that are not as warty looking, but say it was endophytic and maybe a little bit more flat topped, some people might just call them irritated seborrheic keratoses. But whenever it's warty like this, endophytic, I'm more inclined to call it an inverted follicular keratosis, IFK. And these typically occur on the head and neck, and it will look warty clinically. So typically the clinician will ask to rule out a wart when they're submitting this. So this next one, different theme, but this one's actually one that I did not conceptualize until fellowship. And it's primarily probably because where I came from, this is not a diagnosis that was just used commonly. So I had actually never gotten this in a report that I can recall. But you can see from low power, we have a shaved biopsy that's been bisected. And you can see from low power already that there's this lamellar hyperkeratosis and a little bit of slightly acanthosis of the epidermis. So I think formerly, before fellowship, I might have just thought this was what people call a macular seborrheic keratosis, although others will argue that that's a contradictory statement, or the name itself, because seborrheic keratosis is raised, so how could it be macular, which indicates that it's flat? But a flat seborrheic keratosis is what I, in the past, might have called this. But so we have this hyperkeratosis that's above here, and then you can see that little bit of acanthosis. But if you look very closely and you take note of these cells and how they're a little bit larger, and you could even see here that there's a little bit of pigment. Let me see if there's a better example. But here you can see that there's a little bit of pigment at the tips of the rete. A little bit more pigment. So if you keep on going, you could see that these cells, which are larger, actually end up smaller towards the end. I think it's more obvious on the other end. But take a note of how large these cells are, and that there's pigment at the tips. And then they get smaller towards the ends. So it's a little bit easier to see on lower power, but you could see larger cells that become gradually smaller at the ends of this specimen. Here, these are smaller, and then they get larger in the center. And that's where we have this lamellar hyperkeratosis, a little bit of acanthosis, and then the pigmented rete. So this is a large cell acanthoma. So this is not a term that I used quite often in residency. And clinically, they can really be anywhere. Usually on older patients, though, sun-exposed area, you could see that this patient has a lot of solar elastosis below, but they're thought to be on the spectrum with a solar lentigo. So that's why they have the little puppy dog feet with the chocolate at the ends, or the mud at the end, which would look like solar lentigo, but you could see that this one has a little bit more of the hyperkeratosis and acanthosis. So, and the cells are a little bit larger. So that's what you would call the large cell acanthoma. But they exist on the same spectrum with solar lentigo. And clinically, to me, this was my concept of what a macular seborrheic keratosis looked like in residency. So this is a large cell acanthoma. It's benign. Another thing to mention is that besides solar lentigo, when you have large cells like this one doesn't have it, but there's sometimes when you have large cells, you can question whether there's atypia arising and whether it's an actinic keratosis. So sometimes in the same lesion or in the same biopsy, we'll actually diagnose large cell acanthoma, lentigo, and actinic keratosis. Here we don't see atypia or dysmaturation of the epidermis. They're just large. but sometimes it could get to where it looks like a little bit of dysmaturation, and then you can consider that an actinic keratosis. This is one of my favorite diagnoses. As one of the residents here at Geisinger pointed out that I like this diagnosis, but from low power, you could see that this is a pedunculated lesion. Already it's here, the base is where it looks like they shaved it off, and there's a stalk, it's pedunculated. So just talking about the architecture, a couple things can be pedunculated. Well, nevi can be pedunculated, but also skin tags can be pedunculated. Warts can look more pedunculated. Seborrheic keratoses are sometimes pedunculated. So all of those are things that come across as far as the differential in my mind. But you could see that this one has very interesting features from low power. There's a soft knuckling or papillomatous epidermis that's acanthotic. So you could see how it's rounded. So that's my concept of what papillomatous knuckling epidermis is. And even from this power, you can see that there's in areas hypergranulosis in areas and cleared out areas beneath the epidermis as well. So when you see this from low power, before even knowing what site we're on, this architecture with the papillomatous epidermis, the knuckling, not quite, there doesn't always have to be hypergranulosis, but just that knuckling pattern should always hint you towards Condyloma accuminatum. And you should look for the clues then to make that diagnosis. But from low power, you could already consider that. So here you could see that hypergranulosis. You can see the granules in these cells. And let's go to the area where there was more hypergranulosis, but you could see here hypergranulosis, and a key that was pointed out to me in fellowship is that there's rounded parakeratosis. So that's in contrast to other parakeratosis where the nuclei look flatter. These are rounded. So sometimes you might not even see hypergranulosis or coilocytes in condylomas, but you can look for rounded parakeratosis with that knuckling architecture and make the diagnosis. But here, this one's actually a really well-developed condyloma accuminatum, and that's why I picked this particular one, because there are coilocytes in here, not super well-formed, but you could see that there are these cleared out areas, and then kind of like a shrunken nucleus or nucleoli, and so that's what your definition of coilocytes are. And I think there are better areas in certain parts of this, but you could see this all over hypergranulosis, the rounded parakeratosis. And an important thing to do whenever you do diagnose condyloma accuminatum, which is considered a low-grade lesion, is to look for any transformation to a high-grade neoplasm. So in condylomas, we know that it's HPV type 6 and 11, but we need to make sure that there's not any atypia so it's transforming into a carcinoma, whether in situ is what typically we would see here, or invasive. But here again, those coilocytic change. And in this particular lesion, you don't see any atypia to diagnose a high-grade squamous cell neoplasm. So more coilocytes, but like I said, that's not always there. So low power again, we have this pedunculated papule and very papillomatous knuckling architecture. And then looking for the rounded parakeratosis, you can make the diagnosis of condyloma. So we have shave biopsy that's been bisected. And this is, I would say, like after condyloma, this is my second favorite diagnosis. And I've seen this quite a few times, actually, since moving to Danville, Geisinger. And I think we've actually noticed that there are a lot of these in general here. So I don't know if it's the water here or what it is, but I've made this diagnosis too many times now. So low power, you could see that just looking at the stratum corneum, there is a lot of hyperkeratosis, whether this one's more ortho, potentially more para, or it's blue, and it's alternating here. So clinically, you can imagine that this was a very verrucous looking lesion, but alternating ortho, para, very hyperkeratosis though. So wonder what this is from low power. And then also the epidermis, you can see that it's pretty acanthotic. And here there's very skinny, reedy. So a very verrucous plaque. So what could this be? So whenever you think of alternating ortho and parakeratosis, common things being common, you think of actinic keratosis. So could this be just a hyperkeratotic, hypertrophic actinic keratosis, or maybe it's an actinic keratosis on an acral site? But whenever you're looking at this, actually there's clues. So before jumping to atypia and actinic keratosis, there's something that you should always have in the back of your mind. And sometimes it's a little bit difficult to recognize initially. But here we see that there are these towers even here. And looking at the epidermis closely, you could see that there's dyskeratotic cells. So there's dyskeratotic keratinocytes here. And then there's this tower of parakeratosis. And if you look throughout this lesion, you could see again dyskeratotic keratinocytes and this tower of parakeratosis. So that's where the parakeratosis is coming from. And you can see it here, even though it's cut off at the base, but dyskeratotic cells and the towers of parakeratosis. So this pattern actually repeats throughout the lesion. And something that I've been taught now is whenever you think that you have an actinic keratosis, like on the extremity, it's always good to be looking on the periphery, so low power, to see if you see coronoid lamellae. And these actually are all coronoid lamellae. So the typical thing that is described is dyskeratosis and a 45-degree parakeratosis kind of tower coming off of it. These are kind of more or less straight up and down. So that's not always, doesn't have to be 45 degrees, but that's the classic example. And so this one's a little bit different than your run-of-the-mill porokeratosis that you would see where you have towers of the coronoid lamellae on either side of the lesion, and anything can happen in the center. So that's why I mean, if you've seen what looks like maybe an actinic keratosis or maybe a lichenoid dermatitis, or sometimes even like psoriasiform dermatitis, you should look on the periphery just to make sure that there's not coronoid lamellae. And here we have it throughout the lesion. So this is actually a special type of porokeratosis, and this is porokeratosis ptychotropica. And this looks like warty plaques, and it typically presents on the buttock region. And patients will have these huge plaques on their gluteal cleft buttock region, and then you have these towers of coronoid lamellae just with intervals within each other throughout the lesion, so not neatly on the sides like your run-of-the-mill porokeratosis. So this is very verrucous appearing clinically. And I've actually seen it on other sites here besides the buttock, but that's what you should memorize for testing purposes, usually buttock area, but I've seen it on the ankle, I think on the wrist on a patient, But it's a very interesting entity, and it's easily missed if you were just looking at it and then noticing this ortho, para, and you might jump to actinic keratosis. So again, shave biopsy that's been bisected. And low power, you can already see that this is an epithelial neoplasm. It's coming from the epithelium, epidermis above, and it's made out of these pink strands, and then there's like little basaloid buds coming off of it. And this one's a very nice example, but pink strands, basaloid buds. And on low power RD, you could see that it's kind of a fibromyxoid stroma, so a little bit of a busier stroma, but kind of a little bit bluish in color, so fibromyxoid stroma. And again, pink strands, blue buds coming off of it. And let's take a little bit closer look at the blue buds. So I think my differential for this already would be a follicular hamartoma or neoplasm of some sort, or a basal cell carcinoma, common things being common. And so whenever I'm looking up close at these basaloid buds, I'm looking for any apoptotic cells, which could clue me into potentially a basal carcinoma. And also you could look for clefting, which is common in basal cell carcinomas, which I don't see good example of clefting here. There's a couple eosinophils that are bystanders here. Let's look at this piece. So not any obvious apoptotic cells and no obvious clefting that I see. So this taken together, so the epithelial pink strands with basaloid buds makes you think of a diagnosis. So this is Fibroepithelioma of Pinkus. And the name actually makes a little bit of sense if you think about it, but fibro for that fibromyxoid kind of stroma, Fibroepithelioma of Pinkus. And Pinkus is the guy who described this originally, but there's a bit of controversy on this entity because some people regard it as a type of basal cell carcinoma, and that's why it has the blue buds, and they will treat it as such, whether ED&C or whether excision, but as a basal cell carcinoma. And other people believe that it's follicular in origin. And so those who think that it's follicular in origin, they actually, I think, believe that it's a epidermal variant of trichoblastoma. But to me, this has its own name, Fibroepithelioma of Pinkus. And to me, this is more in line with a basal cell. So if I got this diagnosis, I would probably curette it to make sure it's treated. But these typically present on the lower back of older patients. But there still remains debate on what it actually is. This one's an entity that I did not see until fellowship, actually, but we have shave biopsy again, and you can see that it's been bisected. Low power, you can see that there's regular epidermis, and then all of a sudden here, there's hyperkeratosis, a little bit ortho hyperkeratosis here actually, and then an atrophic epidermis. And then the epidermis again gets normal, and then the hyperorthokeratosis ends. So a focal area of orthohyperkeratosis, atrophic epidermis, and then underneath you see that there's a lichenoid interface dermatitis. So this was actually something that I hadn't really seen in residency until fellowship. I saw it clinically, but I never actually saw a biopsy of it. But here, there's a little parakeratosis in here, but that's not the important feature here. But it's just to look at this as a separate little discrete lesion. And clinically, these can present on the legs, but an area of hyperkeratosis, atrophic epidermis, and a lichenoid interface dermatitis. So things that you might consider here, lichenoid dermatitis, in a focal area, you could think of maybe like lichen-nitidus, but it doesn't have that exact architecture of the ball and the claw, meaning the epidermis kind of wrapping around the lichenoid infiltrate. Additionally, you could think of a lichenoid keratosis, common things being common, but this is actually a little discrete lesion with hyperkeratosis. So this actually presents on the legs as discrete lesions, and it's known as Flegel's disease. The other name is hyperkeratosis lenticularis perstans, and this presents on patients on their legs, and it's thought to be an autosomal dominant condition. I kind of liken that to like ichthyosis vulgaris, where patients develop it. It's not of consequence besides maybe cosmetically, but you just see that there's these discrete lesions on the legs. And this is actually a very new entity to me on Histopath. And I think that's my last slide. So thank you all for giving me the opportunity to teach you today, and hopefully you learned something new.
Yeah, I really appreciate it, Connie. Excellent cases, and it was really nice that you were able to bring in the clinical features as well. So thanks so much. You did have one question here. Clinically, can you tell that special porokeratosis apart from porokeratotic osteo and dermal duct nevus? I think clinically, porokeratosis ptychotropica is just, it's so doggone impressive. And at least I remember when I first saw biopsies, I don't know whether this is thought has crossed your mind, but until you really noticed the pair, I was wondering, could this be a horrible LSC, prurigo nodule, or, even some variant of an epidermal nevus with the pair. But the towers of as you pointed out, of cornoid lamellae are so distinctive, and the clinical is usually really characteristic too. Would you agree with that?
Right. And I think the clinical is actually like a plaque, and commonly in the buttock region. So I think that's what really differentiates it.
Yeah, some of the pictures you see, they can be huge, like butterfly plaques on the buttock, and they'll frequently come in. I mean, I've seen them come in with the clinical differential of psoriasis, or extramedullary pageants, or dermatophytosis. Are those the differentials you usually get?
Yeah, and I mean, even I've heard of like hypertrophic LP or discoid lupus and that differential too.
Yeah, they're pretty impressive clinically. Well, again, thanks so much, Connie. Appreciate you.
Thank you for having me.
Okay, take care. Have a wonderful evening. And if anybody has any questions, I put the email here. So please feel free to send them. Thanks again, Connie.
Thank you.